and Dr. Arif, Associate Professor, Radiology, and all other HODs who have found time to attend and to support us to grace occasion. So welcome all, and welcome the postgraduate students, house surgeons, and my dear students, first year and second year. And they have helped us a lot. They are with us, and they are all cooperating with us for arranging this function. And so welcome you all once again, and hope this function will become a grand success with all your moral support. Thank you.
It is our distinct pleasure to invite an exceptional individual who has played an instrumental role in shaping the foundation of our college. We have with us this morning the young and dynamic Trustee and Vice Principal of Sree Mookambika Institute of Medical Sciences, Dr. Mookambika R, who with unwavering commitment and tireless efforts has shaped our college into a center of academic excellence and innovation as we see it today. Ma'am, please deliver the presidential address.
Person sitting behind. What is ART? Art, drawing, or something else? Please don't sleep. Wake up, now. Okay. Before I just want to learn few things from you. Ma'am, can I take 8 minutes of your time? So, what is funny bone? And what is so funny about it? Any idea? Chocolates. Certainly, it is not a bone at all, right? Yeah. So the area near the elbow where the ulnar nerve is close to the surface of the skin. So when you constantly press it, you will feel some sort of tingling sensation. Okay, that's why it is called funny bone. Am I right, madam? Thank you. So correlate the anatomy and the muscle responsible for this. What is this? What's the name of this bird? It's a
duck eagle.
Sorry?
Duck eagle.
It's not complicated, less simple. Our daily life, this used to happen. So being a student, especially in the Department of Anatomy, right in the first year, you should think about this. Correct. Goose. So goose for a Vata Keta, what should come to your mind when you are in first year? Audience. I'm getting answers from this side, but I want answers from the audience. First. Goose? Physiology. Shobha madam is here, your HOD physiology. You are going to appear for exam in front of her. Goose? Bums. Very good. So which muscle is responsible for goosebumps? Very good. Erector pili. Who told? So no chocolate. Okay. So this is what? Goosebumps. Right? So it is caused by the contraction of filling. So how many of you can do this? Okay. How many of you can do this? Please stand up. How many of you can touch your nose with your tongue? I cannot do it. Anybody? Yeah, please get up. Can you touch your nose with your tongue? Yeah. Wow! So why are you different? Why are you different from others? So are you normal or abnormal? Very good, you are normal. So what is this called? If it is abnormal, what is this called? Okay, I think this will be too much for you. This is called Gall sign. Okay, it is called what? Gall sign. About 34% of the general population can do this, so be happy. But 50% of the people with Ehlers-Danlos syndrome, what is that? It is an inherited connective tissue disorder. So 50% of people with Ehlers-Danlos syndrome can have this Gall sign. Okay? Will you forget it? No. Give him a chocolate because he could do it. And he is different from others. So next. How many of you can do this? How many of you can wiggle your ears? I can also do. Morgan sir also can do. So 2 people in this hall. Anybody else? Oh. I think he needs a chocolate. You need a chocolate, right? So how many of you can wiggle your ears? Yes. 1, 2. Okay. 3, 4. All 4 of you please stand up. Each one of you tell one muscle responsible for this. Can you name the muscle responsible for this? Why others cannot do, why you alone can do, and myself, Muslim sir can do? I think 1, 2, 3, 4, 5, 6. 6 people in this hall can wiggle the ears, right? Out of maybe approximately 250 or so. Why? Because our 3 muscles are active. Or we would have trained the muscle to do the job. Isn't it? Just name the muscle alone. Some anterior, posterior, something like that. Obviously, this is an ear. So what is it called?
You should stand up and answer.
Yes. Superior, anterior, and posterior auricular muscles. Usually, these are active among the mammals, but few of the humans can do it, and we are lucky to do that. Okay? Just turn around and see whether you have a tail. So many naughty boys and girls are here, right? How many of you have tail? How many of you have tail? Have your mother ever told you that you are born with a tail when you are naughty? Huh? பிறந்தப்போ வால் இருந்தது, அதுக்கப்புறம் டாக்டர் வந்து சர்ஜரி பண்ணாங்க. My mother had told me, and now even she is telling triumphing also, my daughter. So how many of us have tail? So what is the anatomical correlation for this? Any idea? Somebody have told it rightly. Very good. It is called tailbone.
Tailbone.
Yes. And some can can be born with a tail as well. So that is because of, and these people might have spina bifida which can be corrected surgically. Okay, fine, please sit. So very good answers. So how many of you learn medicine like this? I think all of you are very serious in your studies, right? You read your textbooks so seriously. You will not be happy at all, you will not be smiling at all, you will be just doing like this when you study, right? Or pulling out your hair, and by the end of final year all the hair will come out. You will become bald. Isn't it? So isn't it fun to learn medicine like this? Yes or no? Yes or no? Yes. Yes. So most of the time we are on the race and mugging up things without even understanding the concepts of what is happening within our human body, and we don't even look into the interesting facts of our own body, isn't it? And the primary objective of learning medicine is just to pass the exam and get a degree, isn't it right? So this is how you study for exams, correct or not? The day before exam, if we come to your room, you will be like this, and this is how you feel during an exam. After learning so much, nothing in your head. You will be shocked to see the question paper, isn't it? So, in general, according to me, my concept is this: medicine may be tough and a vast subject for all of us, but it will become easy only if you develop interest in it, and it's not at all hard work. You have to give some sort of smart work as well. Studying medicine involves more than reading. It involves more than looking into the pictures or mugging up. Find your own way to make it enjoyable like this, and this is my way of remembering the concepts, and this which I started doing when I did my MD General Medicine, especially for my basic science exam. Okay, so please have some sort of interest in learning medicine. So distinguished faculty members and my dear incredible future doctors, good morning again.
Good morning.
So anatomy along with physiology, I know all of you will accept that this is a basic fundamental of MBBS or medical curriculum, isn't it? So if you are weak in it, will your foundation be strong? No. I have seen many students, especially when they come to medicine, surgery or OG, they used to fumble a lot because the foundation is very weak. They don't know the basic anatomy as well as the physiology. So this is it is very important to understand the concept right from the first year of your MBBS days. And during my days in 2023, we didn't have such a CME program. We didn't have a chance to sit like this in front of eminent speakers like this. We didn't have a chance to meet such eminent people only. Until the end of my MBBS days. And I'm so happy that you are fortunate enough to meet these people and listen to the lectures from them. And my humble request is to utilize all those things. So in those days in 2003, it is not that old, we had only vertical and horizontal integration, and that too we to sit like you people without any purpose. We don't know what is going on. Our ears will be listening, but eyes will be sleeping, and brain would have already gone to the dreamland. Okay. So coming to the topic ART. So ART, my humble advice is, please don't use short forms. Why? In today's context, ART is Assisted Reproductive Technology or Technique. But according to my perspective, it is antiretroviral therapy, being a physician. So use it wisely. Okay. And you should know what is that abbreviation you are using and where you are using. That is the main thing. So this ART is definitely going to be an advanced topic for you, but understanding that in relation to the basic science will definitely help you when you are actually studying in depth. So having told you about my own theory, at least I guess out of this 250 future doctors, if 10 or 20 would listen to the CME and grasp a very good interesting part in it, I'll be very happy and grateful to you. Okay?
Yes, ma'am.
Okay?
Yes, ma'am.
How many of you want to become surgeons, OGCs and urologists in this hall? How many OGCs? How many OGCs in this hall? How many of you want to take obstetrics and gynecology? Yeah, one male person. Very good. Give him a big round of applause. Nobody in females. How many? Any interns? Very good. So 1, 2. Only 2 auditions in this hall. 3, 4. Again. Big auditorium. And so, enjoy medicine. Happy learning. Thank you so much.
Thank you, ma'am. That is truly engaging and interesting. Ma'am, we would also request you to light the symbolic lamp symbolizing the brilliance within each of us and our shared pursuit of knowledge and growth. We request the dignitaries, Dr. Vinu Gopinath, Dr. Girija Kumari, Dr. Nagendran and Dr. Shobha Kumari to join her for the same. As a mark of respect, I request everyone to please remove their footwear and rise for the ceremony. Students, you are all requested to kindly take off your footwear for the ceremony. Dignitaries, you are also kindly requested to remove your footwear for the auspicious ceremony.
Thank you, dignitaries. You might have heard that is instant coffee and instant tea. It is heard that instant approval, instant permission. That's what happened in our CME. That is lot of requests from that is to go the program with the online. So everybody want to go with the online. So we have not planned for that. We have planned only for the offline mode. So we didn't start off that hybrid mode. Then immediately that is with my mind, with my expert team, they have that is immediately okay. They asked, they are ready. Immediately just I sent a message to Vice Principal Mookambika ma'am, we are a lot of registration all over India, we are getting online mode. Can we switch on to that online mode? Ma'am has given instant permission. Okay, sure, go on. That is happening, and all over the medical colleges in India, there that is live streaming is going on. And thank you so much, ma'am, for giving permission and arrangement and everything. So very glad. Thank you, ma'am. Thank you.
Esteemed members of the healthcare community, today as we are gathered here, let us embark on a journey towards a healthier tomorrow. It is our utmost pleasure to introduce the inauguration of a unique initiative, the Health Calendar. The Health Calendar serves as a beacon for guiding us through the various aspects of a balanced and fulfilling lifestyle, ensuring that we don't neglect the most valuable asset we possess, our health. We humbly request Mrs. Mookambika ma'am to unveil the Health Calendar. Please also join us, Kirja Kumari ma'am, Mukundan sir, Nitish and team from batch of 2021. We also request the dignitaries on the dais to join them as well.
A big round of applause for the team who have done this.
And again, this is a first time we have not used any flex banners for a CME program. So all the artwork done by the students section is very good, excellent. So congratulations once again.
So far, that is for every day that morning that is we are just searching on the net what is this today's social in relation to our health and everything, and we are so far we are searching that net and hereafter we just refer that is our health calendar. That is the SMS complete health calendar, you can use it, and this tool is entirely that is the performing beginning this health calendar. Now I wanted to be a inductor and the initiator, and this group is going to work on the Java platform, and they are in a short period of time they are going to produce an Android app for that is the health calendar. Okay, that is very good. So big kudos to this team and their team for preparing this calendar.
Thank you, team. That was truly an innovative notion that must be celebrated.
To honor is the host privilege. To be honored is the guest pride. Felicitation is one such beautiful gesture of hospitality in any event. We begin the felicitation with our respected Mookambika ma'am. Followed by Nagendra sir, Professor and HOD of Department Biochemistry, Shobha Kumari ma'am, HOD of Physiology, Dr. Elizabeth, Professor and HOD, Professor Pediatrics. We first have Dr. Nagendra sir, HOD of Biochemistry.
I congratulate the HOD of Anatomy
Dr. Kulasekharam for organizing
organizing this wonderful CME. So embryology is a very good topic and the eminent speakers are there. So students, make use of this CME. Best wishes. Thank you.
We now have Kulasekharam ma'am, Professor and HOD of Department Physiology.
Respected dignitaries in the dais and on off the dais, then I am first of all my hearty congratulations and best wishes to all faculty members and non-teaching staff members in the Department of Anatomy for the spirits and spectacular efforts taken for conducting this marvelous academic program. This will be a constant source of inspiration for all the medical education itself for doing further academic programs. And again I take this opportunity to express my heartfelt sense of gratitude to the management, Chairman Sir, Director Madam, Mookambika Madam and Vinu Sir for the immense support given to the for implementing this marvelous goal. So let me once more conclude with best wishes.
We now have Elizabeth ma'am from the Department of Pediatrics.
Most respected and beloved Vice Principal Dr. Mookambika, Dr. Girija Kumari, HOD Anatomy and her whole team, the faculty for today's session, all HODs and faculty members and dear students. This is a great learning curve, I must say. We sometimes say God must be fed up of mankind, but when a baby is born, we know that God is not fed up. And the marvelous things what is happening during this period, and if something goes wrong, the baby will be handicapped and all, but that is only very few. Once in a blue moon we get a baby who is having disabilities, otherwise it's always there. And from infertility we are moving to fertility. I think the titles are all handpicked. So usually we used to say infertility center, infertility specialist. Now we are moving away from that. So a lot of learning things are there, and I congratulate the whole team for this wonderful meeting, and I am happy to be part of it. I wish all the best for this program. Thank you.
I would like to invite Sree ma'am to close the inauguration function with a few words of gratitude towards the honorable dignitaries.
Good morning to all. The essence of all beautiful art is gratitude. I deem it a great honor and privilege to propose the vote of thanks on this memorable occasion. Let me first of all start by giving glory to the Almighty God for making today's continuous medical education program EmbryoART-2023 a resounding success. First and foremost, I thank our chairman, Dr. Veeraida Nair, and director, Dr. Ramavi Nair, for giving us an opportunity to organize the CME. The trustees, young and energetic, Vinu sir and Mookambika ma'am, who despite their busy schedule has found time to grace this occasion and also in inaugurating the health calendar. I also express my sincere thanks to our administrative officer, Prasad sir, and our dean, Dr. S.M. Kannan, for their encouragement and support in conducting this program. My heart fills with lots of gratitude and respect for our distinguished guest speakers for not only sparing their invaluable time for us to grace this occasion, but also accepted our invitation to be here with us for enlightening us with their commendable talk in the subject. My heartfelt thanks to the heads of the various departments, Dr. Elizabeth Koshi, Principal of Dental College, then postgraduates and interns. I thank all the distinguished invitees from various colleges who are present here and watching online accepting our invitation. A special thanks to our UG students, especially the first year and the second year MBBS students, for their enthusiastic participation in course. No event can take shape without a hard-working leader. I would like to express our gratitude to our HOD Girija ma'am for planning and leading this event. It would have not been possible to organize this successful event without her valuable guidance. And even like this cannot happen overnight. The wheels started rolling months ago. It required planning and a bird's eye for details. We have been fortunate enough to be backed up by a team of very motivated and dedicated academicians and non-teaching staff from the Department of Anatomy, and I also profusely thank each one of them for their support. I thank the members of the media for evincing interest in covering the event and all good hearts who worked behind the screen for the live streaming of this event in YouTube. Once again, on behalf of the CME organizing team, I thank you all. We look forward towards a great CME. Let us together make it a grand success. Thank you, one and all.
Thank you, ma'am. Before we commence our journey into the world of EmbryoART 2023, let's all take a short break for 15 minutes. I request all the students to return to the hall by 11:15. The students are requested to wait till the senior faculties and teachers have left, after which you can proceed for the same via the back door. The students are supposed to use the area near the elevator for the tea break, and the respected dignitaries, senior faculties, interns and PGs are requested to use the area near the virology lab for the tea break. Thank you.
பிரேக் ஸ்லைடை ஃபோக்கஸ் பண்ணி வச்சுருங்க. 15 மினிட்ஸ் அது ஓடிட்டு
ஓடிட்டுங்களா?
டீ பிரேக்.
ஓகே. பேட்ரி பேக்கப் எவ்வளோ நேரம் நிற்கும்? பேட்ரி இருக்கும் ஒரு 1 ஹவர் 1.5 மணி நேரம் மாற்றிட்டு வேறு மாற்றிட்டே இருப்பீங்க தானே?
ஆமாம், இப்போ மாற்றினேன்.
இன்னொரு 1.5 மணி நேரம் ஃபுல்லாக தான் இருக்கும். பிழிச்சு போடுவாங்க.
Hello. Okay.
We request everyone to gather back. We request everyone to gather back. We request all the students to gather back. gather back as we begin the scientific session soon.
All your friends.
All the students kindly gather back as we are beginning our scientific session. We request all the students to kindly gather back. Now as we begin the scientific session, we request everyone to be seated.
We now invite Dr. Elizabeth, MD Pediatrics, PhD, Professor, Head of Department Pediatrics, Sree Mookambika Institute of Medical Sciences as the chairperson for this session. To enlighten us about the female fertility problem, we have an individual with a treasure chest of wisdom, experience, accumulation over a period of 29 years. Please join us in welcoming Dr. Sita, MD, Obstetric Gynecologist, Professor, Head of Department, Obstetric Gynecologist, Sree Mookambika Institute of Medical Sciences, to deliver her speech on obstacles and challenges on the pathway to pregnancy.
Very good morning to all of you. After the break, we are running short of time, so we have to make up the time we know. And I am very happy to be part of this CME and the topic on understanding the female fertility problems. And most of the female fertility problems may start in the childhood. Maybe the tuberculosis they had, or the asymptomatic bacteriuria, the urosepsis, or some endocrine problems. Most of this may be there as a child also. So over to Dr. Sita for enlightening us on the female fertility disorders.
Thank you, Dr. Elizabeth. Respected audience and my dear students, so I am supposed to talk on the obstacles and challenges on the pathway to pregnancy, the female factors. Actually, when it should be a concern for us? When will you start running behind these obstacles? Actually, after 1 year of unprotected sexual intercourse of reasonable frequency only, you are supposed to run behind these obstacles, whether there are any obstacles or not. Because 80% of the couple will conceive in 1 year and 90% will conceive in 18 months. But there are some exceptions for everything, no? If the lady is more than 35-year-old, or if there is an obvious menstrual abnormality like irregular periods, infrequent periods and all, she is eligible for investigation by 6 months itself. Okay, the fertility issues are, fertility investigation is required for around 15% of the population in the public. But nowadays, there is an increased demand due to improvement in the ART techniques and all, ladies think, couple think that they can postpone their pregnancy to any age and they can become a mother at any age and father at any age. So the investigation evaluation incidence is more than 15%. Okay. So what are the female, actually female factor contributes only 30%, male factor 30% and combined 30%, and 10% is unexplained. But the initial evaluation, the husband and wife should come together. So you know that the essential steps for the birth of a normal baby, Dr. Mookambika already described. Ovulation should happen first with a competent ovum, and that ovum should be picked up by a patent and potent fallopian tube, not only patent. And a good sperm should reach there to the fallopian tube, and fertilization should happen there, and a viable and competent embryo should be generated. And the transport of the zygote to the uterine cavity also should happen, and it should be followed by a successful implantation in the uterine cavity and a continued growth and development of the fetus and retention of the fetus in the uterus until term. So the obstacles can happen at any of these steps. So when you consider the female factors, this pie chart will show you the tuboperitoneal and ovulatory dysfunction. They contribute for the major, they are the major contribution for the obstacles. Ovulatory dysfunction 35% will be the tuboperitoneal also 35%, and immunological factors, cervical and uterine factors are only 5% each, and 15% of the cases there may not be any reason, actually usually call as unexplained subfertility. You don't call infertility nowadays, either a reproductive failure or subfertility. Okay, so to understand about ovulatory dysfunction, you should know something about ovulation physiology, then only you will understand. I think you are very fresh from physiology and you must have studied the ovulation, cycle and all. The hypothalamus-pituitary ovarian axis should be functioning normally, and there should be normal negative and positive feedback, and other endocrine glands like thyroid and prolactin should be normal, and the selection of dominant follicle is happening, and you will be knowing the two-cell two-gonadotrophin theory of folliculogenesis, and the growth of follicle from the primary follicle, and finally the LH search should happen due to the positive feedback of the estradiol on the pituitary. Then ovulation happens 24 hours after the LH search. Then only a competent ovum will be released from the ovum. So this picture will show you the ovarian fimbriae of the fallopian tube is embracing the ovary to catch the ovum when it is released into the peritoneal cavity, and it is transported through the fallopian tube to the ambulatory portion. The sperm will come and meet it. That already explained, so I need not waste time on that. Okay. So when you consider ovulatory dysfunction, this is the most common but easily to treat also. The other factors are difficult to treat. This ovulatory dysfunction, the WHO has typed into 3 groups: type 1, type 2 and type 3. In type 1, there is a failure at the central level, hypothalamus-pituitary level failure. So it is not producing releasing hormone, so there is no gonadotrophin. So there is no estrogen in the body. That is the problem with the type 1 anovulation. In type 2, there is no failure, only dysfunction is there. The hypothalamus-pituitary dysfunction is only there. So the gonadotrophins are normal, they have got estrogen also. But in type 3, the failure is at the gonad level. Hypothalamus and pituitary is normal, the gonad has failed. So you have to differentiate these 3 groups, then only you can treat the patient. In type 1, only 10% patients belongs to this type 1. The common conditions are anorexia, rosacea, excessive exercise, stress-related anovulation, hyperprolactinemia, all work through this. They belong to this type 1 group. And there is a hereditary condition called Kalman syndrome where associated anosmia is also there. And pituitary failure also belongs to this group 1. And how you identify this group is, you give plain progesterone to the patient, they won't develop withdrawal bleeding, but there is no estrogen in them. So you can think that they may belong to type 1 anovulation. And in type 2, 85% of the patients belongs to this type 2, that is normal gonadotrophic infertility, subfertility.
there the progesterone challenge test will be positive. You give progesterone to them, they will develop withdrawal bleeding. And 90% of this condition, PCOS, polycystic ovarian syndrome, and it is a condition where there is chronic anovulation, hyperandrogenemia, either clinical or biochemical, and polycystic ovarian morphology. We diagnose this condition by Rotterdam's criteria. And the high androgen level disturb the follicular growth. And they have hirsutism, that is the male pattern of distribution of hair in the female is called hirsutism. And they can have acne, obesity, and insulin resistance. And they are from develop diabetes, metabolic syndrome, carcinoma endometrium later on. See, this is the hirsutism. You can see the male pattern of distribution of the hair in the female. And this is called acanthosis nigricans. It is an indication of insulin resistance, thickened hair, thickened skin on the back of the neck, and with the violet pigmentations. And this is the necklace pattern of the ovary scan report of the polycystic ovarian pattern. Peripherally arranged small follicles you can see, and the ovary will be a little bit enlarged also. And the third group, that is only 5%, there is a gonadal failure. It may be either a non-developed ovary or atretic ovary, that sometimes the patient may be chromosomally incompetent, Turner syndrome. They have got only one X, 45X, so the other X is missing. That one is deciding the migration of the germ cells from the yolk sac to the genital ridge. So they will have only little bit ovarian follicles, so they don't ovulate properly. And the other group is a premature ovarian failure, where it may be familial or an acquired failure due to autoimmune disease or radiotherapy or chemotherapy. So this is a picture of Turner. A typical appearance is the short stature, wet neck, wide space nipple and shield chest and all. So how will you diagnose? Because a lady with a regular menstrual cycle, 28 to 34 day cycles, with a mid-menstrual pain and mid-menstrual spotting, we expect that she is ovulating every month. But it may not be the truth always. So some documentation of ovulation is required when you work up. So usually we do follicular tracking, follicular study from day 7 to until the follicle ruptures. It is by transvaginal ultrasound. You serially do ultrasound to study the follicular growth. And LH kit is available, which you can pick up in urine checkup. Urine, like a pregnancy test, LH search can be diagnosed, and you can time ovulation with it. After 24 hours, the ovulation is expected. Mid-luteal progesterone also you can check around 21 to 22nd day. If it is more than 9 nanogram, it is suggestive of ovulation. And endometrial biopsy, even though invasive, it is also just suggestive. Secretory change will suggest ovulation. And basal body temperature, a biphasic chart, is also suggestive of ovulation, not very confirmatory even there. Okay, so actually the clinical approach is totally different. What we do is, when a patient we suspect an ovulation, we give progesterone challenge test. If she develops withdrawal bleeding, okay, maybe a PCO group, you can treat with a clomiphene citrate or letrozole or weight reduction or lifestyle modification. If she doesn't develop withdrawal bleeding, she may be type 1 or type 3. So we do FSH measurement. If FSH is very high, she belongs to gonadal failure. Type 3, there is no treatment active, only egg donation or embryo donation will work. In the group 1, you have to do brain imaging, and you can supplement with the GnRH. Gonadotropins can be given to treat the patient. Either a pulsatile GnRH or a FSH therapy can be given. And karyotyping should be done for the group 3 patients. And brain imaging is advised for group 1 patients. So it should be an orderly investigation. You cannot order a battery of investigation and send the patient. The history taking, examination and investigation should be in a systematic and orderly way. Okay, so that finishes the ovulatory dysfunction. Now we can deal with the next major chunk of problem, tuboperitoneal factors. Tuboperitoneal factors, we usually deal with them together because the pathologies affecting the tube will affect the peritoneum or ovary and pelvic peritoneum also. PID, that is pelvic inflammatory disease. Infection of the genital tract above the internal is called pelvic inflammatory disease. Cervicitis and vaginitis is not pelvic inflammatory disease. So PID and endometriosis. What is endometriosis? It is the growth of endometrial stroma and glands in place other than functioning endometrium in place other than the normal lining, inner lining of the uterine cavity is called endometriosis. And tuberculosis of the genital tract also will come under this group. These tuboperitoneal factors cause either a tubal block or a tubal dysfunction. It may not be block always, it may not be motility disorder of the tube. And the salpingitis, it is called salpingitis. The infection of the fallopian tube is called salpingitis. And gonococcal infection and chlamydial infection is very common condition causing salpingitis. And if a lady gets a attack of PID, single attack, the tubal block chance is 12%, tubal damage. After 2, PID goes up to 30%. So it should be urgently treated. And there are some conditions which cause tubal block like proximal tubal block and distal tubal block. And the proximal tubal block, there could be a mucosal polyp or mucosal debris or chlamydial infection. It's a very silent infection, but it causes a medial tubal block. Unlike a gonococcal infection which causes a distal tubal block, but that infection will be very symptomatic. Fever, discharge, fever, abdominal pain and all. Chlamydial infection is very indolent, you may miss it sometimes. And after puerperal infection and appendicitis, usually you get a distal tubal block. And peritoneal factors usually they cause peritubal or peri-ovarian adhesions. And the typical example results from pelvic inflammatory disease, endometriosis and previous pelvic surgeries. So regarding PID, STD should be ruled out. Chlamydial infection, gonococcal infection should be ruled out. Also tuberculosis. Also gram-negative and gram-positive bacteria also can affect upper genital tract. Pelvic endometriosis, there is 33% association with subfertility. Why there is subfertility in endometriosis? Tubes may be patent, but there is anatomical distortion, there is a toxic peritoneal fluid, and there is a decreased oocyte quality and disturbed ovulation sometimes, and tubal block may be there, and there is defective endometrial receptiveness. So all this will contribute for endometriosis, and these ladies will have severe dyspareunia, so sexual function also will be affected. And the diagnosis of tuberculosis factors, symptoms and signs. Always diagnosis by a meticulous history should be taken, and a clinical examination including general and gynecological examination should be done. And next investigation is an extension of gynecological examination, the ultrasonogram, abdominal as well as transvaginal scan should be done. And we suggest some tubal patency test. If there is no, initially when you take the history, if you think that it is an ovulation, you can try ovulation induction for 2 or 3 cycles, 3 or 4 cycles. Not conceiving, you have to establish that tubes are patent. And if the initial history taking examination shows that there is likely to be a peritopelvic factor, your first investigation may be laparoscopy like that. So you have to modify your investigations according to the clinical history and examination findings. So I am stressing on that history and examination, all aspects, type of infertility, duration, previous history of infertility treatment, menstrual history, sexual, obstetric, all headings in the history taking should be elaborate, and previous gynecological history, childhood history as Dr. Elizabeth mentioned, social history, social sexual behavior, and general examination including body mass index, hirsutism, galactorrhea, any thyroid enlargement, and of course gynecological examination, per speculum and per vaginal bimanual pelvic, any retroverted fixed uterus with a formation tenderness, sudden axil masses, all this should be noted. So this is a normal hysterosalpingogram where you can see it is one of the investigation done for tubal patency. You inject radiopaque water-based dye into the uterine cavity through the cervix using Leach-Wilkinson cannula, and you can see this is the tube with a free spill here. So the normal study of tubal patency. And this is the hydrosalpinx. It's a sequelae of chronic PID. The tubes are dilated. No, there is no spree. See, that's the sequelae of PID. Usually gonococcal or tuberculosis. There will be lateral tubal block. Medially it may be patent sometimes. So in between she discharges all the contents through the cervix and vagina and outlet. It is called a hydrops tubae profluens. And this is an ultrasound picture of the endometriosis, typical endometriotic cyst in the ovary with a low level internal echoes and posterior acoustic enhancement. Typical appearance of chocolate cyst or endometriotic cyst in the ovary. Okay. Anyway, laparoscopy has brought a lot of advantages to diagnose tuberperitoneal factors. It is diagnostic as well as therapeutic. You can diagnose tubal block, peritubal and perihepatic conditions. That is Fitz-Hugh-Curtis syndrome. You must have heard about that. Also, you can diagnose hydrosalpinx can be removed as well as diagnosed, or you can do cuff salpingostomy along with that. And femoral occlusion can be released and diagnosed. Then ovaries, you can diagnose chocolate cyst, PCOS, tubo-ovarian mass can be diagnosed. And uterine myomas can be localized, and endometriosis can be diagnosed, staged, and treatment also can be given, fulguration, excision and all. So this is a picture of hydrosalpinx. You can see that retort shaped tube here, enlarged tube. This is the normal tube. It's a sequelae of chronic PID. And these are hissing ovaries, enlarged ovaries behind the uterus. The typical endometriotic chocolate cyst, endometrioma of the ovaries, bilateral. Usually bilateral pathology, they are hissing ovary usually. It will be adherent to the back of the uterus also, to the broad ligament. This is a powder burn appearance in laparoscopy of the endometriotic spots. You have to fulgurate all this. And this is a chocolate cyst is broken during dissection. Chocolate material is coming out. Okay, so that finishes the tuberperitoneal factors. So there are some problems in the tubes and peritoneum and ovaries that can interfere with the fertility. So you should know the basic causes and how will you proceed with that. Now we will deal with the uterine factors. Uterine factors can be anatomical or functional. Functional, very rare luteal phase defect or non-receptive endometrium. The anatomical factors, usually they cause recurrent miscarriage and implantation failure rather than subfertility. The intrauterine additions, you call Asherman syndrome, there is an implantation failure. It is due to the damage to the basal layer of the endometrium due to deep curettage or cesarean section or myomectomy, and the patient develops intrauterine additions and it will be an implantation failure. Fibroid, it's a smooth muscle tumor arising in the uterus. It can disturb the uterine cavity, cause tubal block and affect the uterine contractility and can result in miscarriage, implantation failure and sometimes fertility problems. Adenomyosis is endometriosis interna, endometriosis affecting the uterine musculature. It will result in implantation failure. Uterine polyps also will result in implantation failure. And uterine malformations, you know the development of the uterus from two Mullerian ducts in the absence of a fetal testis. So there is no Mullerian inhibitory factor. The Mullerian duct will develop into two ducts are they fuse in the lower part and form the uterine cavity and upper vagina, and the unfused end will result become the fallopian tubes. The lower part of the vagina is developed from the sinovaginal pulp. So the fusion defect or failure of the resorption of the uterine, this embryological level can result in uterine malformations which can lead to miscarriage or preterm labor and implantation failure. A septate uterus usually only the one which causes subfertility. And of course, infections of the endometrium, tuberculosis, chlamydial infection can result in implantation failure. So this is the picture of fibroid. All fibroids will not cause. The one distorting the uterine cavity, that injecting into the uterine cavity, type 0, 1, 2, 3, 4, 5 will affect the fertility. And this is the laparoscopic appearance of the ovary, not ovary, uterus with the multiple fibroids, you can see. And this is a submucous fibroid. Like a baby, it is sitting in a very small one, sitting in the uterine cavity, but it will interfere with the, even if it is very small, it will interfere with the implantation. So it is a real obstacle to the birth of a normal baby. So these are uterine anomalies. The uterine anomalies, I already told that it can be a fusion anomaly or a resorption problem. So this is the normal one, and this is a independently developed two uterus from both Mullerian duct. It won't interfere with the fertility much. Some preterm labor only described, but arcuate uterus and unicornate uterus, they cause miscarriage and preterm labor, and bicornate and septate uterus, especially the septate is the culprit. It causes infertility as well as miscarriage. So you have to correct this septum by hysteroscopically. You have to resect with the laparoscopic guidance. Otherwise, you will perforate. Any septum more than 1.5 cm should be resected by the hysteroscope. What is hysteroscope? Because you pass the hysteroscope through the cervical canal, And you will get a panoramic view of the uterus when you distend the uterine cavity with some fluid, using the lactate or saline, and you can see the entire uterine cavity. And with the resectoscope, you can divide the septum without opening the abdomen. So diagnosis of uterine factors is a history again, dysmenorrhea, all this heavy menstrual bleeding will be there, clinical examination you will get an irregular uterus, and transvaginal scan you can do, and 3D scan is very good in diagnosis. There is no need to do MRI for all to diagnose uterine anomalies. 3-dimensional scan is very good. HST and histoscopy, hysterolaparoscopy also you can do if you want, if you are in doubt, and saline infusion sonography also is will delineate the uterine cavity. So this is the histoscopic view on this side of the uterine septum, and this is a owl-eye appearance in the ultrasound, bicoordinate uterus. The 2 endometrial cavity you can see on the ultrasound, and this is a septate uterus on HSG. The septum is very deep. Here is the septum. So you have to resect the septum. Then only the patient will get a normal pregnancy. And this is a bicoordinate uterus. There is a depression instead of this. Okay. Then this is separate uterus, diadelphys. All these are HST, hysterosalpingogram pictures. Unicoordinate uterus, only one side developed. They can have a rudimentary horn, and even if you treat, ectopic can develop in the rudimentary norm. The rudimentary horn can be there. So you have to excise that rudimentary horn. Otherwise, there is no treatment for this condition. You can do lateral metroplasty and all, but it will be a preterm labor, something like that. They don't have infertility as such. And this is a filling defect in the HSG. The fibroid is sitting here. You may have to remove that hysteroscopically if it is jutting into the uterine cavity. And this is multiple intrauterine adhesions. You can resect these adhesions by hysteroscopy and put in a Foley's catheter and give estrogen so that it will heal. And this is a uterine polyp which will include the implantation, it will result in implantation failure. And so that is over uterine factors. Then cervical factors, cervix is the gatekeeper to the uterus, So if the cervical secretions are not friendly, sperm cannot enter inside. So cervical infections, cervical stenosis, scarring, all will cause subfertility. But we are not concerned because of the IUI is there. We can put into the uterine cavity the washed sperms. And anti-sperm antibodies are also seen in the cervical mucus, which also we don't test nowadays. Post-coital test is not done nowadays because you can bypass all this with it. It is not confirmatory, that's all. IUI is very simple and you can use that to overcome these problems. And towards my end of my lecture, this is immunological. There is immunological factors. Sperm antibodies can be there in this blood and cervical secretions of the lady. And IUI is the answer. Intrauterine insemination is the answer. And advanced stage, unexplained infertility. Actually, we don't know whether it is unexplained. It can be a subtle endometriosis or PID or luteal phase defect, or there is a condition where the follicle shows all features of ovulation but it is not ruptured, almost trapped follicle. So all this can explain the infertility, but it is still called, initial evaluation there is nothing. So you call it as unexplained infertility. You have to do hysterolaparoscopy, then only you can comment on that. It is really unexplained or not that. And remember that advanced stage is a very important factor, female factor. When the age is advanced in female, the ovarian reserves go down and the quality of the ovum will go inferior, and there can be genetic abnormalities and mitochondrial deletions in the ovum. And ovarian reserve you can measure by measuring FSH on day 3 of periods. It will be more than 10. And IMH and inhibin, anti-Mullerian hormone and inhibin will be low in such people. And antral follicle count, you can, by doing ultrasound, you can count the follicle in one ovary with the follicle size between 2 and 8 millimeter. More than, less than 10, 8 is not very good. More than 20 is PCOD. So ideal is between 8 and 15 or 20 like that. So that also is a test for ovarian reserve. So thank you for the patient hearing. I know that I was running fast because it may not be an undergraduate level sometimes, but only limited time is there. You can ask. But now after presenting this, it is a wonder how patients become pregnant. It is not a wonder why they are not becoming pregnant. So the most gift, the the God has given a very valuable gift for us, the babies, no? It is such a complex and mechanism, as Dr. Morgan said, but even after conception, such a lot of hurdles you have to pass, no? So that is my conclusion. So take her message. Don't think that challenges and obstacles you have to run behind immediately after marriage. You have to counsel the patient that reasonable interval you have to give. Don't do unnecessary investigation. A bacterial investigation is not an answer. You have to work out systematically by clinical history examination and plan the investigation accordingly. That is my message.
Thank you, Dr. Seda, for very systematically explaining all the reasons for subfertility among women. I think because of lack of time, we will conclude. I would like to tell this young crowd one message that most of the fertility specialists say. Don't unnecessarily postpone your reproductive functions because of career or learning objectives. That is what the problems are more as the age advances. That is the message we want to pass. Thank you very much.
Thank you, Dr. Sita ma'am. That was truly an eye-opening and immersive session. We humbly request Dr. Elizabeth, chairperson of this session, to present the speaker with a token of appreciation. Thank you, ma'am. We invite Dr. Peena Paul, Professor, Department of Microbiology, to present Elizabeth ma'am with an award for her contribution to this session. Thank you, ma'am.
We have with us next an expert in his field renowned for his extensive research and contribution, Dr. Vinod Gopinath, to enlighten us about male fertility problems. With due regard, let me also call upon Dr. Alex Arthur Edwards, MS General Surgery, Professor, Department of Surgery, Sree Mookambika Institute of Medical Sciences, as the chairperson for this session.
Good morning, everyone. Am I audible? Okay, so first of all, I want to make a correction. I am not an expert in this field. Actually, an area of urology which I most neglected is andrology. So yeah. So with that being said, when Madam approached me, I thought, okay, I'll share whatever. And because it was told that it is more of an undergraduate teaching, so okay, my knowledge should be sufficient. So you have listened to various aspects, and you have gone through the female infertility. Now coming to male infertility, like the topic obviously is very much advanced for you, but a basic understanding of the basic sciences will help you in actually understanding the problem when you deal with it more in depth. Okay. So yeah, you must have gone through all this, no? What is infertility, the definitions and all. So regarding male infertility, the contribution of a man for fertility is only the sperm, right? The only contribution by a man is the sperm. Rest of everything is happening in the female body, right? So the entire problem of male infertility is from the production of sperm to the delivery of sperm. That's it. The entire problem happens in this area. So we need to know what is the male reproductive system. You know all this, and I don't think we need to go through all this. Okay, so spermatogenesis. Spermatogenesis again is a very complex process. Depends on a lot of factors. So it has to be regulated, right? How is it regulated? lot of hormonal factors are there, right from your brain in the pituitary, hypothalamus pituitary axis, giving off various types of hormones. Hypothalamus giving a controlling regulatory hormone, then the pituitary secreting some luteinizing or these hormones. Then there is a action on the testis. From the testis, again there is spermatogenesis. This, depending on the action of these hormones, there is spermatogenesis, and it also releases another hormone, inhibin, which goes and acts again on the pituitary, giving a negative feedback, right? So now, all these will be going through. Yeah. So from this basic flow of how it is being regulated. So first it has to be regulated, then there is a production, then there is a delivery, right? So the problem can arise in any of these areas. So, sorry. Yeah. So any of these areas. So first is, that is before anything happens in the testis, before the spermatogenesis, there is a control of the spermatogenesis. So anything that happens before anything happens in the testis is called as a pre-testicular cause, right? That is in the regulatory area, there is a hormonal problems, right? Next comes the testicular cause, any problem which happens with spermatogenesis, where the regulation is okay, but the testis is not able to produce a proper sperm. That is a testicular cause. Then from once the sperm is formed, the delivery of the sperm is problematic. That is post-testicular causes. And finally, the sperm itself may be defective. That is sperm-related factors, right? Yeah. So, like I said, pre-testicular causes may be due to LH-FSH problem, causing a defect in the stimulation of the spermatogenesis. Again, so in that will come all your unhealthy lifestyles, diabetes, hypothyroidism, hormonal factors like hypothyroidism, hyperthyroidism, hypogonadism, etc. Everything is hormonal. Okay, you write some hormonal deficiency for as far as your exam is concerned. Any hormonal deficiency, it will usually be a pre-testicular problem. Next is testicular problem. The testis itself might be problematic. Like it must be having some, like Klinefelter syndrome. The testis is agenetic. There is a deficiency of the tubules which produce sperms. Then defective sperms are being generated. The spermiogenesis itself might be defective because of all these congenital anomalies. Then there are acquired disorders where again the testis is damaged, like following chemotherapy. There is suppression or destruction of the tubules. Then pathologies which cause, you know that spermatogenesis is dependent on temperature, right? Temperature, again things causing increase in temperature in the testis, like varicocele, cryptorchidism, orchitis, hydrocele are other things. And there are few other areas also here. Lifestyle disorders, I'll be talking about that. Yeah. Then of course once the sperm is developed, you have to deliver it to the female genital tract. Again there might be issue with the transport. Like once it is developed here, it has to go through the epididymis, it has to go through the vas deferens, it has to come here, it has to enter the ejaculatory duct, seminal vesicles have to contribute, the prostate has to function for the ejaculation, and finally it has to go through the urethra into the female genital tract, right? Anything in this area can be problematic. Like it can be a prostatitis, infection of the vas deferens, epididymis, epididymitis, urethritis, orchitis, any inflammation. You put an itis on all this, everything is a problem. Prostatitis, right? A trauma to the testis, causing damage to the testis, right? Sometimes following a surgery. Okay, so what you have to understand is, sperm is a haploid thing, right? Sperm is haploid means it is not having the same genetic makeup as our normal body. So what happens is, if the body is exposed to sperms, it will consider it as an antigen. So it can develop anti-sperm antibodies. Okay. And then in the urethra, what is hypospadias? Anybody knows? Hypospadias? It's not hypospadiasis. Many people make that mistake. It's hypospadias. Anybody knows what it is? Hypospadias, epispadias. Yes? Anybody? No? So hypospadias is when the urethra ends in the ventral aspect, okay, more proximally than where it should actually end. Okay. Epispadias is if it is ending dorsally. Okay, that epispadias is usually associated with the evaluation of diaphragm, bladder anomalies and all. Okay. This one is usually a problem of the fusion of the urethral tube. Okay. So epispadias means the urethra will be ending somewhere here. So the sperm will not be deposited in the female genital tract. It will be deposited outside, right? So all this and cystic fibrosis. What is the problem with cystic fibrosis? What is cystic fibrosis? Anybody knows? Yeah, the genetic defect is what? What is the problem that? Not increased, more. No, okay. Not increased mucus secretion. No, mucus will be much more thicker. Okay, it becomes very clumpy, kind of, it will not move. Okay, so semen becomes very thick. The volume decreases. It becomes very, it becomes a very problematic thing. So again, the transport of sperm is affected, right? Then of course, impotence. Then retrograde ejaculation. There is something called as a retrograde ejaculation. Usually happens when the following prostate problems, when they take medicines or they have a surgery, the internal sphincter. There are two sphincters controlling the bladder. Okay, the internal sphincter and the external sphincter. The internal sphincter is located in the bladder neck and the prostate region, and there is an external sphincter here. Okay, during ejaculation the internal sphincter has to close and the external sphincter has to open. Okay, when these people take this medication, the internal sphincter remains open. So what happens, instead of the semen going out, the semen goes inside the bladder. Okay, and it is voided in the urine. So again, transport of sperms is affected, right? Then finally, surgical orchidopexy. Like orchidopexy, a descent of testis. You know, the descent of testis at any point it might be problematic. It can stop. It can be an abdominal testis. It can be a undescended testis in the inguinal canal. Okay. So nowadays the studies say that it is not because of the descent problem, that the descent is because of some genetic problem or defect in the testis per se, rather than a defect which is happening because it has not descended. That the cause and effect relation has changed. So what they are saying is, even if you bring the testis down and surgically place it in the scrotum, it may not help. Okay, because there is an inherent problem in the testis which has caused it to not descend. Okay, so that's why in a history, when you take history of orchidopexy, all is important. Again, retroperitoneal or pelvic surgery, all these are important because retroperitoneal surgeries can damage a lot of nerves, which are important for this, like again, bladder neck surgery, prostate surgery, which I explained before. Okay, then again our lifestyle and other normal factors like age. Age again impacts some cellular function. The multiplication is problematic. The sperms might be more defective. The spermatogenesis is affected and sperms may be defective. Then lifestyle diseases, like I told, obesity, alcohol consumption, all this will cause problems in the spermiogenesis proper. Pathophysiology we have already, environmental, again, this is one common thing which is becoming more frequent nowadays, tight fitting underwears. Right? Most of them are using very tight, not only underwears, even the dress is very tight. Okay, that itself will cause rise in the temperature, compression of the testis, that itself can cause damage to spermiogenesis. Right? So our students can take, we give them loose fitting dresses, they will go and alter it and make it tight. Okay. Yeah, so ladies, note this in prospective grooms and all. Okay. So again, hot baths, saunas, all of this cause increase in temperature. Again, defective spermiogenesis. Right? Yeah. So evaluation is a sum up of all this. You have to remember all these causes, ask the history for all this. And examination you have to ask, you have to see something. This I am not sure whether you will be able to diagnose from this. This is a Klinefelter syndrome. You can see the white set nipples and all. Okay, look for virilization. What is virilization? Virilization is development of what is virilization? Development of virilization is development of secondary sexual characters. In men it will be chest hair, right? Chest hair, axillary hair, okay, muscle mass and all that. Look for adequacy of virilization. Gynecomastia shows what? More feminine hormone predominance, right? Look for thyromegaly, again hormonal issues. Thyromegaly, nodule. Look for any hepatomegaly or features of hepatic dysfunction. What are hepatic dysfunction? One sign you will look for hepatic dysfunction. That is fine. One sign you look for hepatic dysfunction. Jaundice, yes. Jaundice, simple. Look, think about simple things first. Then you have to examine the genital tract. Look at the penis. Look for hypospadias. Examine the scrotum. See if it is of adequate size. Any evidence of surgery. Look for any deviations. Okay. And surgically, you always have to do a perrectal examination. Unless you do a perrectal examination, an abdominal examination is not complete. Okay, abdominal in females a pervaginal examination and perrectal examination. In men a perrectal examination is very much important to complete your abdominal examination. Okay. Yeah. So while you examine, first you check the testis, then run your thumb over the testis to look for the epididymis, then run your finger above, hold it with both your fingers to check the was difference. Okay. You will be learning this. How many of your second years and how many of your first years? Majority are first years only. Second years anyone? Yeah. So you must be learning the examination and all, right? Okay. So this is how we will look at the spermatic cord. Okay. You have to hold this, look for any lumps, thickening, cord and all. What is this? You can see the what is this? What can you see? What are these? Veins. Dilated tortuous veins. Dilated tortuous veins. In dilated tortuous veins in the testis or scrotum are called varicose. Same thing in the legs are called varicose veins. Okay. Yeah. Again, the problem is the same. In both these areas, the problem is poorly functioning or inadequate valves. Then, like I told, a rectal examination is very important. You palpate the prostate. Actually, rectal examination is much more complicated than that. You have to look for the tone of the anal sphincter. You have to look in, when you say anal sphincter, the anal sphincter is a bulbo-spongeous complex which regulates both the urethral sphincter and the anal sphincter. Okay. So when you are checking the anal sphincter, you are also evaluating the urethral sphincter. Okay. And then you have actually with the tip of your finger you will be able to feel the bladder, ejaculatory duct, and seminal vesicles. And you have to feel the sacral promontories. You have to feel the mucosa of the rectum, and with the middle phalanx you have to feel the prostate. The base you feel the sphincter. Okay. Yeah. Then of course semen analysis is another thing, where semen analysis, once the semen is produced, is it of good quality? Like so far the pathology has been for production of semen, sperms. Now, are the sperm of a good quality enough to fertilize the egg? So you have semen analysis, of course, low sperm count, whether it's having an abnormal morphology, is it an abnormal sperm, and is the sperm motile enough to reach the ovary? Not the ovary, over. Okay. And yeah. So all this hormonal analysis also you can do, regulation of to see whether any of these hormones are deficient, right? What is the problem with prolactin? We didn't see prolactin here, right? When we discuss about prolactin, again has a negative effect on the testosterone production. Okay. Thyroid again is thyroid causes metabolic problems, which in turn affect the spermiogenesis. Evaluation again, various different types of, you will be learning all this as you go on. Okay. So ultrasound is the first imaging that you do for evaluation. You have to image the ultrasound and ultrasound of the abdomen and scrotum. Okay. You cannot just image the scrotum alone. Ultrasound abdomen and scrotum. This is not required now. Nowadays nobody does that. This is more of urology topic. Okay. And finally you go for a testicular biopsy. You take a small piece of testis and look at the tubules and all and see whether it is of good. And finally just a few take-home points. Most of the infertility in men is about 30% is idiopathic. Okay. No matter what you evaluate, you will not be able to find the cause. And nowadays what happens is everybody tests for everything. Don't go for that. Take a good detailed history, tailor the investigations for each patient. And finally, male infertility, most of the time, given time, they will conceive if you give the adequate supportive measures like loose underwear, good lifestyle and other things. Most of them will recover. But if it is not, then you can of course manage surgically through artificial reproductive techniques. Thank you. I have brushed through, I don't think you will be able to grasp much more than this. So I have tried to concentrate more on the causes rather than this one, so that you will be able to add on to your knowledge later on in your life. Okay. So yeah, any doubts? No, it's a bit too much in the first year. Okay, let me tell you some things regarding embryology. I was listening to Sir's topic very. The problem with embryology, learning embryology is there are too many terms. Too many terms are there. One, there will be a crest, there will be a mesoderm will be there. Immediately in the next sentence it will become mesenchyme. Right? So this is the problem. So what I will tell you is, each word try to understand what it means. understand the meaning of that word. Most of them are Latin. Okay, understand the meaning of that Latin word so that you will be able to apply it. Like sir told, somatopluric, splanchnopluric. Somato means what? Body. Somato is body, splanchno is visceral. That is the organ. So anything with somato is dealing with the body. Anything with splanchno is dealing with the organs. Okay. So understand that and initially try to avoid all the terms. Just learn that it is forming a tube, then it is forming this one, then this tube is breaking up into this thing. Without the terms, try to learn that, and then later on, as you understand it, you add on the terms. Embryology is a bit difficult if you learn with the terminologies. Okay. Why mesoderm becomes mesenchyme is because once it starts dividing, it becomes a jelly-like thing. So it becomes mesenchyme then. Okay. That chyme means a jelly-like thing. Okay. So try to understand the meanings of each, and then it will become much more easier. It's a very difficult topic.
Thank you, sir. It was a nice presentation, more than an undergraduate level.
Yeah.
But students, you should understand that after you are getting married, don't postpone the first pregnancy. So you can plan the second child later, 10 years, 12 years, or no child after that. So first thing, don't postpone. And so much of the couple come there, the boy will be in Gulf and the lady will be in the town. So that fellow will fly, and the 14th day or 13th day, be here for 1 or 2 days and go back. And next day, the next consultation, the lady will come and I don't have any issues. So this is not just like a mission, coming, doing the job and going back. So you need lots of psychological factors. You have to stay together, and togetherness is very important for fertility. And only one thing I want to add, sir, this the varicocele we can do connection with the laparoscope. As you all know, that's called the lap coagulation. Previously, we were doing open surgery, ligation of the dilated veins.
Varicocele, the thing is, the varicocele is better treated by a distal veins, so it will be more proximal approach rather than a distal approach. So the problem is with testicular veins, it has initially it will be multiple. Okay, too many vessels, then it will join, and in the abdomen it will become 1 or 2. So if you dilate the veins more proximally, it has better results than when you ligate distally. That is, distal is abdomen in this. Okay.
Only thing, if you dissect carefully, testicular vein alone, along with it you will have a testicular artery. You have to be very careful and teach the peritoneum and do that. So, and another thing, before that, if the sperm count is normal, you don't venture all these things. You have to go for the reassurance and the advice the couple. So other things like sperm retrieval are not needed for them.
Too much for them. I think what they need to understand is the cause, history, how to approach the history with regard to the cause.
And physical examination, as you told, is a must. You have to always examine the breast. The male patient coming with infertility, you examine the testicles as well as the breast. You have to examine thoroughly the patient, and palpation is very important. You look for the testicular sensation. As sir has told, epididymis, you have to palpate carefully. Thank you, sir.
Thank you, sir.
Any doubt from the students?
Sir, with the permission. Yes. Sir mentioned about causes, that is the occupational causes, that is hazard. That is, we all are using, that is the cell phone, isn't it? You can notice a lot of research is going on, and articles says that you are using a cell phone nowadays, that is from 3G to 4G and 5G, it is going on. So the frequency is more, that the studies have shown that using a cell phone, keeping in the pocket, or using a cell phone here in the inguinal region with the pouch is reducing your sperm count. Lot of articles are there for the boys and boys who are not married. Be careful about this occupational hazard. You are always keeping that, because say that testis is also in the scrotum, outside the body, because it can't withstand that temperature. But for girls, you can use a cell phone 24. It doesn't matter, because whatever is inside the abdomen doesn't matter. It is not going to affect. Okay, so that one point. Thank you, sir.
fertilization is more important for good quality sperm production. I advise all the male to get cool water bath. Avoid the hot water bath.
Ice water.
No, not ice water. Never take hot water bath. That is also. Moreover, you have to change your lifestyle. So ask the patient to avoid smoking, drinking, everything has some role over the fertility.
Thank you, Professor. That was really eye-opening. We would now like to request Alex sir to present a token of thanks to Manu sir for his remarks. We also cordially invite Dr. Subaratnam ma'am, Professor of Surgery, Sree Mookambika Institute of Medical Sciences, to present an award to Alex sir. Thank you, ma'am.
To present you our next speaker, Dr. Sheila Balakrishnan, MD, DMD, FRC OG, Professor of Reproductive Medicine, Government Medical College, Thiruvananthapuram, to speak about Assisted Reproductive Technology. Let us, with our own respect, welcome the chairperson of this presentation, Dr. C. Nirmala, MS, Obstetrics and Gynecology, Professor, Department of Obstetrics and Gynecology, Sree Mookambika Institute of Medical Sciences.
Respected Chairperson, good morning everybody. At the outset, let me thank especially Dr. Girija and the entire team of organizers for having invited me today. I'm very happy to be here. My job has been made easier by the previous two speakers, so I don't know how much you're going to understand. I tried to make them with many pictures, as they say. So I think everyone knows, anyway, more than antiretroviral therapy, everybody knows assisted reproductive technology. That is a good sign. So ART, we are bypassing the natural process here. Now recently, I don't know how many of you are aware, the ART law has come into action. Anyone is aware of that? It is in all the papers everywhere. Medical students don't read papers, isn't it? And they don't see the news. Anyone is aware of the ART law? No. Okay, in 2000, I'll put it in the end. 2022, the ART law has come into, it has become a bill, it has been passed by Parliament, and so now there are a lot of regulations. Because there were a lot of problems with assisted rape. I think everybody knows that, a lot of commercial and all these problems, and now everything is becoming streamlined. So before we used to say ART was only handling of the oocyte outside the human body. So that when you handle the sperm, for example in intrauterine, have you heard of IUI? Intrauterine insemination? No. Okay, that is just handling the sperm outside. But now, after the ART Act, it is involving handling of the gamete. So either the male or the female gamete, once you handle it outside the body, it is termed as assisted reproductive technology. And according to the new Act, there are two levels of ART. One is the level 1 center and the level 2 center. So level 1 centers will be able to do only IUI, that is only handling the male gamete. Level 2 centers will concentrate on IVF, in vitro fertilization, etc., where they handle the oocytes also. So I'll come to that. So the important thing is that on one hand you have the infertile couple. Then you have the general gynecologist who sees all these patients in the beginning, and then finally you have the IVF specialist. So it's a duty of the general gynecologist to be in the middle and coordinate the activities, so that when they have to decide when to send a patient for IVF and all that, not too early, not too late is the dictum. Like Dr. Sita already said, it's don't jump immediately after marriage. There's no need to this thing. But certain places, when the woman is elderly or when you have a definite cause, then you must think of treatment. That is important. So I am just going to talk about which are the patients who will require assisted reproductive technology, a little bit on how you evaluate the woman prior to ART, and then mainly ART procedures. So selection of ART, this is again brush up of what you already heard. I think male factor, all these things. So as the previous two speakers have emphasized, everything depends on history and physical examination. After the history and physical examination, you can most likely rule out ovulatory dysfunction. When you know that the woman is having irregular periods, you know 95% of women with ovulatory dysfunction will be having irregular periods, and along with that hirsutism etc., you know she is having PCOS. So that is diagnosed. When there is severe dysmenorrhea, chronic abdominal pain, you will be thinking of tuboperitoneal factor. We leave all this. Male factor, obviously all the things in the history which the previous speaker has mentioned about. And then we go on to all these things. And a word which unexplained infertility has already been told to you after the initial history, physical examination, and there is an initial gamut of tests, which I will just tell you, and then you say 10 to 15% will not have any problem, and then you just clump them together as unexplained infertility. It's not that they have no cause, they have a cause. Many times when you take them for in vitro fertilization, we find there are defects in the sperm, oocyte, etc. And finally, this is a term which is coming up again and again, low ovarian reserve. It depends upon aging of the ovary, which I'll come into detail again. So, history, physical examination and the initial test already mentioned. What I would do is a semen analysis definitely as a first line. So by the end of the semen analysis, you know whether it is normal or abnormal, and if you have not done an examination, you must definitely do an examination and move in that way. Second, doing all the hormonal tests which are necessary, thyroid, irregular periods and all those things, doing thyroid etc. and I'll come to that. Third, doing a proper ultrasound scan, because ultrasound scan is just an extension of physical examination. Abdominal followed later on, always we do a transvaginal scan. So by the transvaginal, so semen analysis will tell you about the male factor. From the history and the examination you can find out ovulatory dysfunction, or your ultrasound will tell you all about tuboperitoneal factor. Not only ultrasound, looking for tubal patency. I think Dr. Sita has already mentioned there are different methods of looking at tubal patency, hysterosalpingogram, laparoscopy, etc. So from these two, ultrasound and that, you can make out all these things, tuboperitoneal factor. Uterine factor, again ultrasound will tell you. Cervical, we are not so worried about today because we are usually bypassing the cervix in intrauterine insemination. Unexplained infertility. If at the end of these four things, you are doing a semen analysis, a proper baseline scan of the woman, the necessary hormonal tests and testing for tubal patency, you find that it doesn't fit into any of these, it comes here as unexplained infertility. Low ovarian reserve, I'll take it as it comes. So coming to which are the patients who need to have IVF. IVF is not for everybody, please understand that. And when I talk about IVF, I include ICSI also, which I'll come in. IVF is, I think you all know what IVF is, isn't it? Yeah, in vitro fertilization. So what is fertilization? Is in vivo, it is occurring in vitro in the lab, that's all. Then you have an extension, ICSI. What is ICSI? Intracytoplasmic sperm injection. You may or may not do it depending on the situation. So definite indications for IVF. You cannot do anything else but IVF. Tubal block, which I'll come to, what the type of tubal block. Severe endometriosis. A woman with previously used to go for surgery in severe endometriosis, but then we know any surgery on the ovary is going to destroy her follicles. So in an older woman, or when you have large cysts, very severe endometriosis, today we are moving away from surgery and towards IVF at an earlier age, because the first attempt is always the best. And severe male factor, which will include absence of sperm. What is absence of sperm called? Azoospermia. Okay, so these three things, definitely these are first line indications. So tubal problems, if tubal surgery is not a realistic option, always IVF. And today, most of the time we go straight for IVF. So this is already shown to you, a normal hysterosalpingogram, and this is, you do a laparoscopy, this is the uterus, this is the ovary, and this is the fimbriae of the tube, and you find the dye spilling out, you know that the tubes are patent. So this I think has already been shown. This is a, what is this? Let me see if you're, what is this? Yeah, this is the uterus, and this is the tubes which are filled with dye, and the lateral end is blocked, and so it is a hydrosalpinx. This is distal tubal block, where you, and another case of distal tubal block where you can't see it really. This is also a hydrosalpinx. Dye has been put inside and the dye is not coming out, it's become bulbous here. So distal tubal block, today we do not go for surgery, you go straight for in vitro fertilization. And this was the condition where IVF was done for the first time also. I think all the causes have been already described. Just remember, mainly pelvic inflammatory disease. Now, proximal block is again, when you have a proximal block, the hysterosalpingogram shows proximal block. That means the dye is not entering into the tubes. It could be due to minor problems or major problems. Like, then you would do a hysteroscopy. What is a hysteroscopy? Anyone? Have you heard of the word laparoscopy? Yes, you know what laparoscopy is, isn't it? You put a telescope into the peritoneal cavity and through that you can diagnose and you can also do all the surgery that you, what is the only surgery that you can't do laparoscopically? Anyone? Cardiac surgery. Cardiac surgery is also being done. What else? What surgery cannot be done? Cesarean section, obviously, isn't it? Except cesarean, everything else. The baby cannot come. Who knows in future what's going to happen? They may make it small and then make it big again. Like in that movie. So when you have proximal, so again, as I told you, ultrasound, and then the next thing that we are fond of, not for all patients, will be hysteroscopy and laparoscopy. So laparoscopy, you're looking inside the peritoneal cavity, so you can see the uterus, tubes and ovaries. Similarly, what is hysteroscopy? Yeah, into the uterus. And so you can see the inside of the uterus. So this is when the inside of the uterus you find, this is the corner of the uterine corner where the tubes take off and you find a small polyp there. It can be easily removed. So such cases, in proximal tubal block, there is definitely an indication to do a hysteroscopy and find out if there is a correctable cause. A small polyp can be removed. You can also try to cannulate the tubes. This is called, I think the urologists do it all the time with ureteric catheterization. Similarly, we have tubal cannulas are available and you can use that to try and bypass the obstruction. But if these fail in proximal tubal block, also you will go for IVF. So tubes, definite indication for IVF. Next, endometriosis, as I already said, I think pictures have already been shown to you. This is the same picture. This is a picture of bilateral, what do you call these ovaries? Kissing ovaries, yes, very good. Why are they kissing? Because there's a lot of adhesions there, isn't it? What is inside this? What is the other name? Endometrioma or chocolate cyst. So it's tarry, chocolate, old blood. And the blood starts leaking and then it causes a lot of adhesions. And as a result, you find that the ovary and the tube are not, the egg and the sperm are not able to meet. There's a lot of adhesions, distorted mobility and all these things. And apart from that, there will be some inflammatory problems also. So in all these cases, when you have severe problems like this, so endometriosis you have 4 stages, minimal and mild, moderate and severe. But in most of the moderate and severe cases, today, as I said, we used to do 10 years back, we were doing a lot of surgery, but today the number of surgeries done is coming down because each time you touch the ovary, her ovarian reserve. What is ovarian reserve? It is the number of eggs. It is the quality and the quantity of eggs. So what is the best marker of ovarian reserve? Age, obviously age. But we find that many times chronological age will not and ovarian age may not go together. It may be congenital, it runs in families, mothers have early menopause, women, the children also. Then any surgery on the ovary, radiotherapy, chemotherapy, all these things. So that's why endometriosis, severe cases best to go straight for IVF. In mild cases you can try other methods like IUI. You can do a laparoscopy and then go for IUI. But again, if there is no success for IVF. So these are all, And if this is just a picture of a surgery being done, you aspirate the fluid and then you do a cystectomy. When you do a cystectomy, see, this is the inside of the cyst wall only should be removed. This is the outer wall which contains all the follicles. And we should not injure the outer wall as much as possible. Now the third definite indication for IVF is when you have absent sperm. Azoospermia, evaluate for surgical. Now even if there is absent sperm in the ejaculate, sometimes the testis may contain sperm, isn't it? I'll come to that. So in such cases, there are what we call a surgical, you can remove the sperm by surgery and then go for IVF ICSI. Again, when you have a very low motile count also, you can go for IVF ICSI. So both azoospermia and very, very low counts, you can try IVF. Now, these are the first line indications: tubes, severe endometriosis, severe male factor. Coming to the second line indications, you try other things and then if it fails, you go for IVF. So like unexplained infertility. You can try IUI. IUI is you're just washing the sperm, taking the best sperm and putting it inside the uterus. So what are you bypassing? You're only bypassing the cervix. One thing you're bypassing the cervix. Second thing, you're getting the best motile sperm in a small volume. Normal 7 volume is 1 to 1.5 ml. Here it comes into 0.3 ml concentrated motile sperm. So you're increasing the chances. You put it inside the uterus. So you can try IUI in unexplained infertility, mild male factor and mild endometriosis. In these three areas, you can try other modalities of treatment. You can even try laparoscopy, and if it doesn't work, then or if the endometriosis becomes severe, go moving for IVF, but definitely not as first line. Now, ovulatory dysfunction or polycystic ovarian syndrome, IVF is only a third line indication after all other things have failed. So PCOS, we don't directly go for IVF. And if you were to ask me which would be the best type of infertility to have, it would be PCOS because it's very, very eminently much better than male infertility. Yes, so this is all what I already said, unexplained infertility. Yeah. So you can go for, in unexplained infertility, you can even tell them to wait for a couple of years. Nothing is going to happen. Because in the West, there was a big study which looked at just waiting, expectant management and compared it with IUI, and they found that IUI was not cost effective. So you can either go for expectant management or you can stimulate with IUI, but again your results are going to be less than 15%. Anyone can tell me the pregnancy rates with IVF? I just want to know what you think would be the pregnancy rates with IVF. How much? 70. One person said 70%. Anybody else? Yes? 85%. Oh my God, this is, if medical students think, I'm getting scared. This is how patients think, isn't it? In reality, the best centers in the world have only 45% success rates with IVF. Remember that. And so when we counsel our patients, we tell them 35 to 40%. Any center which tells you that you have results of 75 to 80%, they just, I mean, what is it? They're just bluffing. So don't believe anybody who says that. You get lots of holdings everywhere, isn't it? 80% results with IVF. So even with that, and then you go to IVF in all these cases. This is just a picture of intrauterine insemination. This is the uterus. This is a speculum which is put inside the vagina. And then what do? The lab, they will prepare the sperm. They centrifuge and wash the sperm. The sperm has to be washed to make it free of prostaglandins, because if you put neat semen is unwashed semen. If you put neat semen inside the uterus, all the prostaglandins will cause cramps. So you have to wash it, remove the seminal vesicular fluid, prostaglandins, and concentrate the sperm into less than 0.3 ml. And then it is given to you in a catheter, and using a non-touch technique, you just insert it. Don't touch the fundus, it should go below the. What will happen if you touch the fundus? Again, contractions will occur. You put it inside. So as I said, in mild male factor, mild endometriosis, unexplained infertility, all these things you can try IUI, but remember only 10 to 15% success rate. So how many cycles would you do? There are people who do 20, 30. I've had patients coming to me after 35 cycles of IUI. Please remember, not more than 3 to 4 cycles. And everything depends on two things: the age of the woman and the ovarian reserve. So there are ways to look at the ovarian reserve apart from age. So in older women and women with low ovarian reserve, see, suppose a 39 or a 40-year-old woman comes to me, definitely I will advise IVF straight away, unless the patient is not willing, financial considerations, or the ovarian reserve is very good, which is unlikely. Now, just a word. So these were all the indications, first line, second line. Just a word about ovulatory dysfunction. When we say ovulatory dysfunction, what do you think of? First thing that comes to mind. What is the cause? PCOS. Very good. So PCOS, as Dr. Sree already mentioned, what happens in ovulatory dysfunction? Ovaries are not ovulating. So you have to give medicines Everything else is normal. The hypothalamus is normal, the pituitary is normal, the axis is normal. Only lots of follicles in the ovaries. And you need to release the ova. That's all. So you can try oral medication, letrozole and clomiphene. Second line medications are there, even laparoscopy is there, but we don't do it much. IVF is only third line. So for example, if you find that all the other methods are not working, or multiple follicles occur, what will happen if you get multiple? You give all these, in ovulation induction, you want only one follicle to develop. So suppose I find 4 or 5 follicles are developed, what will happen? I think I was already talking about that in the morning. What will happen? Yeah, you get multiple this thing, isn't it? And you don't want that. So in such cases, you have to cancel the cycle. So if multiple follicles develops on simple ovulation induction, you must go for IVF. In IVF, you have the option of what? You need not put back all your embryos. You can freeze the embryos. So everything is in your control in IVF. Whereas in IUI, things are not in your control. In ovulation induction also, things are not in your control. So if you find too many follicles, you have to cancel and go for IVF. Is it clear? Because the first principle is what? The first principle is not giving her a baby. It is safety. Only after safety, the second is giving her a baby. And when you have a quadruplet or a quintuplet pregnancy or ovarian hyperstimulation, another thing that can come. These are all life-threatening situations. Okay, now just I put this. We talked about the first line indication, second line. These are the newer indications for IVF. Has anyone heard of PGT? What is the full form of PGT? Pre-implantation genetic diagnosis. So you have so many today. PGT, you can find out so many problems. There are different types of PGT, looking for chromosomal problems, looking for single gene disorders, everything can be found out. So if you find a woman, a couple who is at risk for having a genetic problem, a single gene defect, thalassemia, all those things, in such cases, to enable PGT, you will have to do IVF. Because what are you doing? You're growing the embryo and taking one cell of the embryo and sending it for genetic studies, chromosomal studies or genetic studies, and then you freeze the embryo. And then when the results come back, you can choose the embryos which are good. So this is pre-implantation genetic diagnosis. So in such cases, you will have to do IVF. These are special indications. Another very, very important and beneficial area where IVF is found to give a lot of benefit is fertility preservation in cancer. You can preserve sperm, you can preserve oocytes, you can preserve embryos. So sperm, testicular cancer, all these things you can preserve sperm. Then not only testicular cancers, lymphomas, leukemias, or anywhere, it need not be ready. Whenever chemotherapy has to be given, the oncologist should be aware and they should send the man should be counseled about freezing sperm, because freezing sperm is very, very easy. And if you know that freezing, and today the freezing techniques are so good that it is up to infinity. Embryo, suppose the couple is there and they have, breast cancer or anything like that. Breast cancer for the woman, or lymphomas, leukemias. If she has a partner, you can go for IVF and do embryo cryopreservation before the chemotherapy or abdominal radiotherapy. If she is an unmarried woman, oocyte, the egg can be cryopreserved. So this has become a wonderful boon to humanity today. Now this is oocyte cryopreservation in endometriosis is also coming up today in a big way. In severe endometriosis, when you diagnose when the girl is very young or the woman is young and she doesn't have a partner, again you can preserve her ovaries. The last one is controversial for those who will not take the advice to have their first child earlier, delayed childbearing and social IVF, oocyte cryopreservation. Do you remember about 10-15 years back, there were a lot of headlines in the papers. Infosys gave a lot of incentives. Infosys and many other big countries gave incentives to their women employees, saying that all of you go and freeze your eggs. Why did they do it? Because they wanted maximum output at that time when they are young. So they said, you go and freeze your eggs. We'll give you money to freeze your eggs and then you can put them back later. Don't become pregnant now. So that was a lot of controversy. But still that is something, some people may use it. Now just a word about ovarian reserve. As I already said, it is not the quantity alone, it is the quality also. Aging of the ovary. See, just look at this picture. This is how the follicles are arranged at birth in the ovary. They are tightly packed together. This is what happens at 25 years of age, they are very, very here and there. And by the time the woman is in her late 40s, it becomes like this. So this is what is ovarian aging. So in generally we say that age parallels chronological age, but it's not always so. Now I'll just skip through this before we go into ART. How do you evaluate the woman? Now two things, what do you think? What do you think are the things that you need before ART? Anyone? You know what ART is? You're taking the sperm, you're taking the egg outside and putting it. So what are the things that you should know? Yes? Okay. So 3 things at least. First, you should know her ovarian reserve. How are her ovaries going to act? Because what are you doing in ART? Basically, even though the initial IVF was in a natural cycle, today what do? We stimulate the ovaries. And when we stimulate the ovaries, we want to get more number of eggs, isn't it? Because the more number of eggs you get, all will not be good. What we call as metaphase. We want eggs in the metaphase 2 stage. If you remember your embryology, metaphase 2. So metaphase 1 also, if they become metaphase 2 outside, you can take them. So the more eggs you get, you are only probably about 80% would be good eggs. Then again, the sperm should be good. And lastly, so the ovarian reserve, the main, no offense meant because I kept it last, but still it's very important. Then third is when you put them back, assessing the cavity and endometrium, because you should be putting it back in a good environment. So you should look at the ovaries, you should look at the uterus of the woman, any other factors affecting IVF, and then finally male factor. Assessing ovarian reserve, you want to, there you're looking at how good is your patient. Is she going to respond normally, or is she a very poor responder? She's not going to give you many eggs, or will she go overboard and become a hyper responder? What type of patients will come in this? Anyone? PCOS, excellent. Who said that? Very good. So PCOS patients will come into this, and then you will get lot of eggs, multiple follicles, and even problems like ovarian hyperstimulation. So for this, to find out which type of patient your patient is, you have to do ovarian reserve test. Sita has already mentioned about anti-Mullerian hormone, which is a test that we do. I'm not going into the details. Then another thing is on ultrasound, you count the number of follicles in both the ovaries. Follicles between 2 to 9 millimeters. You count 2 to 8 millimeters. So this is, you count all these follicles. This is on 3D, you get them in different colors. It's very easy, and the machine itself tells you how many 2 millimeter follicle, how many 3 millimeter follicle. So anything more than 15 is taken as a hyper responder, less than 5 is taken as a poor response. So with all this, so by this, so now you know what type of patient. So first of all, her age, secondly her anti-Mullerian hormone, and then looking at the number of follicles. So you know when you start stimulation, how is she going to respond? You should have an idea, because it is very important to counsel the couple. So when you counsel the couple, you cannot just tell her. So counseling a 27-year-old woman and a 40-year-old woman is not the same. So you have to give them the success rates for their age for that particular patient. And now the law insists upon that, individualized counseling. Now second is, once everything is formed, the egg and the sperm and the embryo is formed, you're going to put them back. So you need to know how the cavity is. And for that you do ultrasound. This is what a normal cavity would look like. You get a very good triple line endometrium, and this is when I see something like this, I'm happy. I know that everything it's going to be okay. Again, sometimes, what is this? It is a hysteroscopy. So when you are in doubt, you can do a hysteroscopy, and this is again a normal cavity. This is the ostia on either side, and this is a normal cavity. So all these things are telling you that everything is fine. You can, so when the things like this are there, so this is a polyp. When ultrasound is showing a polyp. This is a polyp. So when you see something like that, you have to remove the polyp. And when you're doubtful, you can even put saline inside. So you do the scan, you can put a little bit of saline inside using a small catheter, and it's very, very clearly seen. This is called saline infusion sonography. And then you post her for a hysteroscopy and remove the polyp before you go for IVF. So this is a very irregular endometrium. This is already shown to you. It is a Asherman syndrome. Again, anomalies, I'll just skip through this. These are all uterine anomalies. This is a 3D recut, 3D. So when you do an ultrasound, you have 3D ultrasound also today. You can reconstruct the uterus. So when you suspect a septate uterus, you do a 3D reconstruction, and you find that, see, this is the outer contour. So this is a wide septum. So a thick and a wide septum. So this septum has to be resected using a hysteroscope. So all these things have to be done. So the same patient. So this patient, this is the same patient, when we did an ultrasound, we found the septum. Then we did the laparoscopy, you find a very broad uterus. Can you see? So it's like almost as if the two uteri have not joined together properly. It's a fusion defect. And then from below, when you do a hysteroscopy, you find the septum and you can just cut the septum to make the cavity normal. So, as already said, there is definite evidence to remove a septum. Small septa need not be removed. Now, what about fibroids? Fibroids are the commonest tumor in the human body, I think. So, it's probably 1 in 3 women have a fibroid. So, the main thing is to remove or not to remove. All fibroids need not be removed. As already mentioned by the previous speaker, only it affects the endometrium. So, she showed you the different types. So, something like this. See, this is the endometrium. You can see the triple line endometrium and this is a fibroid. So, something like this you have to remove. So, how to remove it? It can be removed from below. So, this was a hysteroscopy, and in this hysteroscopic picture, she had 3 large fibroids. It had to be done in 2 sittings. So, large fibroids, definitely this woman is not going to become pregnant, whatever you do. So, she was for IVF. So, in 2 sittings, we removed all these 3 fibroids and she conceived. So, this is hysteroscopy. And suppose the fibroids are from above, then you have to do it laparoscopically. Understand? So you have to decide whether to do the fibroid, remove the fibroid from below or from above. And for that, something that will help you is, again, if you remember for the polyp, we put saline. Here also you can put saline and then you find, see, all the saline is going in and you can find that this fibroid is definitely, you can remove it from below, which is less invasive. Other strategy before IVF, lifestyle is very, very important. So stop smoking, overweight, obesity, nutritional factors, folic acid, all these things, rubella, vaccination. So everything has to be, so the man and the woman must be healthy before. Then this has already been mentioned, so I'm not going to, this is a hydrosalpinx. So it's like this, see, this is the uterus, this is the tube, this is the tube. So when you have a hydrosalpinx like this, there is toxic fluid in the hydrosalpinx. And that fluid will, see, only this portion is closed. This portion near the uterus is open. So all these toxins will come into the uterus and they can be embryotoxic. So always before IVF, if there is a hydrosalpinx, you have to remove the hydrosalpinx, or you can even clip it here. Even if you clip it, that's fine. So the fluid should not go there, that side. That's very important. Again, severe endometriosis, as far as possible, we try not to do surgery, but sometimes, see, when you get a picture like this, large, these are chocolates, and the follicles are all here. So now the needle will come like this from above. When you are removing, in IVF, we put in a needle to aspirate the follicles. So here, when the needle comes like this, you have to go through this chocolate cyst. So in such cases, large cysts, or when there is an obstruction to your aspirating the follicles, you need go for surgery. Otherwise, as far as possible, before IVF, we try to avoid surgery, because once you touch the ovaries, the ovarian reserve will go down, the number of eggs you get will be less. So surgery is indicated only if you anticipate difficult access or there is severe pain. Polypectomy can be done. Yeah. Okay, coming to the male. First thing to decide is, are you going for IVF or ICSI? Now for severe male factor, azoospermia and severe male factor, you have to do ICSI. Otherwise, I mean, if the male factor is normal, you can try in vitro fertilization. I'll come to that. Then a recent detailed semen analysis is important. Antibiotics, antioxidants may be useful. We do not have much evidence. Sperm preparation, just as you prepared sperm for IUI, here also you need to prepare sperm. There are different methods, swim up, density gradient, etc. to get the best sperm, because we need the best. You are choosing. See, the disadvantage is with natural cycle is, in natural cycle, natural selection is occurring. So naturally the best sperm will go. But here you are choosing the sperm. Always we ask for a semen backup in the previous 1 or 2 weeks, because you can have performance anxiety and the man may not produce a sample. So semen backup is important. Azoospermia, I am not going into details. I think you have already mentioned all these things. So I think just now I will talk about it as we come. Now coming to the main ART. So these are all the, what do you have in ART? You have IVF, in vitro fertilization, ICSI, where we go one step further and we artificially take the sperm and put it inside the egg, and embryo transfer, obviously. Second is You can cryopreserve today sperm, oocytes, embryos, anything can be cryopreserved. Cryopreservation systems are excellent. They are almost 98% survival with cryopreservation. In cases with azoospermia, you can surgically remove sperm from the testis or the epididymis and use it for ART. Third party reproduction. What is third party reproduction? Any example? Surrogacy. Everybody knows about surrogacy. You have ovum donation, sperm donation, embryo donation, which is not allowed today here, and surrogacy. There is also 3-parent IVF, that is mitochondrial donation. Suppose the woman has there is a mitochondrial disorder in the mother. Mitochondria is usually from the egg or the sperm. Where does the mitochondria come? Egg, only not sperm. Yeah, so only egg contains mitochondria. So if the woman has there are mitochondrial diseases. So if the woman has a mitochondrial disease, what can happen is you can take the sperm of the couple, the egg of the couple, so the chromosome will be from the mother. But you can take a donor's mitochondria alone and insert the mitochondria into that egg. And then, so that is again 3-parent IVF, mitochondrial donation. So, lot of advances are occurred. Even third party reproduction, 3 people are involved, but even if 3 people are involved, only 2 are actually giving the biological material, isn't it? You have to also be very, very gentle. And finally, when you are going to put it back, you should already have tested